Hi and good evening everyone, and welcome to this joint EUROGEN ERNICA webinar. My name is Olivia Spivak and I am a project manager for ERNICA. Before I hand over to our speakers for today, I would like to take this opportunity to tell you a bit about the ERNs. European Reference Networks, or ERNs, are networks of hospitals and patient organisations from across Europe, working together to support patients with rare and complex diseases, their families and healthcare professionals. This is done by pooling together expertise, knowledge and resources from across Europe. The ERNs were set up in 2017 by the European Commission, and each network is focused on a different rare and/or complex disease area. Two ERNs have teamed up to set up this webinar today. That's EUROGEN, the European Reference Network for Rare and Complex Urogenital Conditions, and ERNICA, the European Reference Network for Rare Inherited Congenital Anomalies. And it's going to be on the topic of Duhamel versus transanal endorectal pull-through, or TERPT. This webinar will be presented by Jonathan Sutcliffe, paediatric surgeon at Leeds General Infirmary, Ramon Gorter and Joep Derikx, both paediatric surgeons at Emma Children's Hospital in Amsterdam, and Ivo de Blaauw, paediatric surgeon at Amalia Children's Hospital in Nijmegen. So without further ado, I would like to welcome Jonathan Sutcliffe.
Hi, thanks very much indeed for the invitation to come along and talk today. Really appreciate it. Lovely to be part of this group, or just to have some input into it. And please do ask questions as we go along. So I've got a little video that we put together with colleagues. Can I just check first of all, can you see this screen?
Yes, it's perfect, Jonathan.
Okay, right. So what I'm going to do is talk through 4 steps really. First of all, is decision making about how to decide which bit of valve to do the pull-through for. That's a generic issue. The second thing is to talk through how to do the retrorectal dissection for a Duhamel, and how to do the anastomosis, which is at the level of the dentate line in the Duhamel, so a little bit lower than for other procedures. Thirdly, it's how to form the pouch with a stapler, and then finally, it's how to make the pouch the right length so we don't end up with spurs. Going to just chat through a couple of general things to begin with. We do this open. Now, we obviously do minimally invasive surgery, and we do have a robot. Our view has been that we reckon that our outcomes are, we believe, to be reasonable. We believe that the additional costs, if you like, of doing an open procedure is a relatively small price to pay for some of the other medium and long-term outcomes. You could argue it either way. I will talk a little bit about different reasons for doing that. It's really sort of getting the top of the pouch right, so we're not too close to the. We don't think we get a lot of spurs. The child that I'm going to show you in the videos had a stoma. We have a stoma rate of 30 to 40%, which is consistent with other centres in national studies anyway. When we've reviewed ours, we think that only few were what we would call avoidable. And in fact, you can have too low a stoma rate. So we're not advocating a staged repair, but for some children with long segment or true failure to wash out, or with other comorbidities like cardiac, with a cardiac referral centre, then sometimes a stoma is just the right thing to do to get them sorted. Ivo is asking about what sutures we use. Most of the anastomoses are done with 4O Vicryl. And the other thing to say is that any one procedure differs between centres, and over time within centres it will be the same for most procedures. I've learned this from working in Nottingham as a trainee. I've learned a lot from my colleague Ian Sugarman. I've learned a little from Jack Langer when we co-wrote a chapter. It's always one of those things you learn most from is when you write with colleagues from other places. And of course, I've learned a lot from my own mistakes. Initially, access, as I say, we do an open phalange seal, low lithotomy with the legs low enough down that we can make the phalange seal incision precisely in the skin crease, and we put a catheter in situ, bladder catheter in situ. Later on, we have for a long time used a Lone Star retractor for reasons that I'm going to explain. For a while, we went back to using silk stays, and you'll see that in this video. But actually, we've used Lone Star for quite a while, and the placement of the Lone Star pins differs. So I use a Barron blade, which is a circular blade, to make sure that the incision is curvilinear and stays properly in the skin crease, and that's good for cosmesis down the line. So actually, from a cosmetic perspective, I don't think I've never seen a patient struggle. We would do a standard phalange seal by dissecting down onto the anterior abdominal wall. You dissect up to the umbilicus. Obviously, if there's a stoma in situ, keep away from that. So you'll see we've gone further up on the left and the right. You'll see here I'm showing that you can make a longitudinal incision, but actually transverse gives you much better access. So we do transverse, even though it's muscle cutting. We cover this with an epidural. Going into the peritoneum is just a standard, whichever way you would normally do it. And then once you're through and just about to go into the peritoneal cavity, this is a point where I arrange for somebody to collect the specimen, because workflow is important. You need to keep everybody interested and involved and not hanging around. So going into the peritoneal cavity, just as usual, and then we need to be controlling the bowel with a pack, just as standard. Decision making now about how to determine the level of the pull through. The focus internationally really is microscopic, isn't it? You do biopsies and see whether or not the biopsies show any suggestion of a transition zone, whatever a transition zone is, however it's currently defined. But actually, there are macroscopic clues. We generally see that there's a muscle-bound coat of the bowel in what we would consider to be the transition zone. So we usually go above that. We usually go 5 centimeters above that. The other thing that I'm going to show you is that the vascular markings on the bowel is abnormal in the aganglionic and probably the transition zone as well. So we look at that. We generally go about 5 centimeters above, because there is evidence, good evidence now from other places, that shows that the junction between the ganglionic and the transition zone is not a straight line, it's wavy. It means that if you just took one quadrant biopsy and that happened to be at one point on a wave, it's quite conceivable that the transition zone extends to a different level on a different quadrant. So that is, if you did an anti-mesenteric biopsy, it may be that the transition zone is extended more proximally in one of the left or the right quadrant or the mesenteric. So we do a donut, and we send a 2 centimeter donut for the pathologist to review on table, all 4 quadrants. So we do that. And I'm just flagging the fact that nobody that I'm aware of will do functional analysis, and actually our current evaluation of what's histologically adequate, I think probably will change, and I hope it does within whatever career I've got left. We send a 2 centimeter donut. We've learned over the years that the submucosa plexus is the important one, not the myenteric plexus. It's possible to have thickened nerve fibers that are probably relevant there, and we checked this with Raj Kapoor, who's I'd say the doyen of pathology, works in Seattle, and just to say we only look at full thickness biopsies, and we look at the submucosal plexus. And then the last thing I'd say is that you'll see when we put the stapler on to do the donut, we do it parallel to the mesentery for technical reasons that I'll explain. So This is the video. So as you can see, classic aganglionic. You can see abnormal vessels. You can see the vas, and hopefully you'll be able to see ureters in a second. And there we are. And moving up, we've identified the top of the muscle-bound bowel, marked it, made a little window in the mesentery, put a GIA parallel, because when we do the anastomosis later on, it needs to be pulled through in that configuration. So we send the donut, and next we mobilize the proximal bowel. We use, as it's open, we can use bulldogs easily. We mobilize the bloodless plane on the left-hand side. Usually go up to the splenic flexure and take that down so there are no bands. Sometimes when I've not done that, I've noticed the transverse colon can get quite full of gas. Make sure that you've got enough length. We look over the pubis and see that it goes down to the anus, but usually that's about 5 centimeters. Do not do the retrorectal incision until you're sure that this is not long segment disease, because you don't want to be in a position where you've already done the retrorectal dissection and you've then got to do a pull through at an age that you wouldn't normally do. So we wait for the pathology to come back, which for us is 40 to 50 minutes. This is doing the mobilization of the proximal bowel, going up to the spleen, and this is mobilizing the arcades. You can usually take 2 or 3 arcades without problems, and you can get length quite easily here. We've easily got a lot of length, and actually sometimes you deliberately take a little bit of extra length if it's going to make it lie better. Now this is a downstream bowel. You can see the transition zone here, and you can see the abnormal markings down there, perhaps you could do before. So the retrorectal dissection, identify the ureters and vas and protect them, or the tubes in a female. Dissect close to the mesentery or to the wall of the bowel, to avoid going to the IFA. Keep going down to the peritoneal reflection, and when the leaves of the mesentery diverge, you know you're going into the retrorectal space. It's really easy to get into that plane. It's a lovely filmy layer, areolar plane, and you can dissect it easily, initially with scissors or a clip, and then you put your finger in and then pledge it to get down to the actually the level of the skin below the anal canal initially. Put your finger in to make sure you haven't concertinaed the sphincter with your pledget, and then put your pledget in again and sweep it from 3 o'clock to 9 o'clock. So retrorectal space into the back of the colon. So here we are. This is a camera from above, again identifying ureters, dissecting down. You can see here the mesenteries diverge. This is a little hole that we're going to develop. Doesn't have to be huge. In fact, it's better not to make it huge to protect nerves. And goes the pledget, and it goes down. This is a camera from above, down beyond the anal canal, down to the level of the skin. The Lone Star pins, as I say, are an important thing to get right. For the dentate, for a Duhamel, we make the incision at the dentate line. So do not put the Lone Star pins in once and then move it a second time to hide the dentate, because what we found that does is it prolapses the mucosa over the canal, so it comes down towards the skin. So when you make an incision at that point, you're then going through the sphincters. So put the Lone Star pins in gently. You're not putting them in for a long time because we're not doing a lot of dissection this way, but still put them in gently to avoid overstretching the sphincters, and don't put them in twice. Mark the dentate line at 6 o'clock and then round to 9 o'clock and 3 o'clock, and then open circumferentially onto pledget at that level. For some centres, Toronto, I know Jack Langer would make his incision at about 0.5 centimetre for a long segment and other centres go vertically, but I've not seen data that meaningfully compare outcomes for these different approaches. One thing that we do is we put our sutures in now. We put them in sort of 2 stages. So we put our sutures in for the anastomosis and leave the needles on before we then do the pull through, because then you've got better visualization of where you want to put your sutures, so you've got more precise suture placement. So silk stays, and make no apologies to say it's effective, but not as good as Lone Star can do it properly. So this is the pledget going down. This is the incision at the dentate line over the pledget, and then you've got a hole there for the pledget to do the pull through. You can see that. We then put the sutures in sort of 12 points, just like a clock face, and we organise them quite carefully. It's a lot easier with a Lone Star retractor. We just dangle them off that and go all the way around. So the sutures at the bottom are important. You've got to get the right depth. If you take too much, you'll take muscle and it will make it too painful. You probably disrupt the orientation or configuration of the canal. So you have to take huge bites there. And now the pull through. It's vital that you remember that you can still twist the pull through even open. So orientate the bowel. We'll put silk on the mesenteric and proline on the anti-mesenteric. Track the mesentery right back to its base, because you know that it before you actually commit to doing any suturing, because you can get it twist up within the abdominal cavity. The sutures are already in place. As I say, be careful about suture placement. Don't take too deep bites on the posterior wall. Don't put too many sutures in. Obviously, if there's a significant gap, close it, but too many sutures can cause problems as well. So once we've made the space and we made the hole, we put our clip through. We've got the valve that we're being careful to orientate properly and marking it as you see. Then we are done the pull through, marking the bowel to remove it. We did this child had a stoma, had washouts, but there was still quite a lot of stools, so we're aware of that. Clean it out, and then we do the anastomosis using the sutures that have already been placed. Makes it relatively straightforward. So we go around, so I'm just going to jump a little bit. Okay, so when all the sutures are in, if there's any spaces that you want to close, close them. Then oops, sorry. Okay, so the next thing is you make the pouch. You use a stapler. We use a 60mm endo-GIA. One fire ends up being 5 centimeters. Some people for long segment go 1 to 2 centimeters. It's important to remember that the top of the staple line to the top of the pouch is what would become a spur. So you don't want that to be more than 1 centimeter. So as you can see here, the stapler is in. The anterior leaf goes into the native rectum, posterior into the pull-through bowel with 1 fire. Check it, take the sutures out, and then take the Lone Star pins out. Check the position. So now the top of the pouch is really important. Keep everybody switched on, because everybody relaxes at this point. But this is an important anastomosis. It's important that it's as close as possible to the peritoneal reflection. Put stays on as low as you can, really at the level of where the top of the staple line is, so that it gives you enough tissue to then close over it. So it's only usually about 6 millimeters above the staple line. So once you open, you empty the rectum, you're interrupted, and then a continuous layer. So if you were to do it laparoscopically with a stapler, as people have done, it's hard to get the angle right, and you compromise things, so you end up with a spur. You can do it laparoscopically sutured, but people find that very difficult at the end of a procedure to get the precise suture placement right, but it is possible. We've got a robot. You could do this robotically. There is proof of concept. There are 3 papers, but one from a really good surgeon found that the mean age of operation was 29 months, so that carries its own morbidity. And another study from a huge centre that does 60 cases per year found that the robot produced limited benefit compared to laparoscopy and was slower and produced a worse scar than the other minimally invasive procedures. So getting the top of the pouch, as I say, we're going quite low to the peritoneal reflection, we're emptying out the stool, and we're putting interrupted sutures just as with any other anastomosis, and 2 layers, and you should see that it falls back down into the pelvis, so you can hardly see it at the end. So here it's dropped down well below the bladder. So we've shown the 4 different steps of the procedure, things that are just to cover quickly. We fast for a couple of days, probably give antibiotics for too long, we give 5 days. We don't do dilatations post-operatively, and we don't need to do irrigations. We've not needed to so far. We do an EUA at 2 weeks to make sure there are no adhesions between the staple line, which would form a spur for a different reason. Complications early are pain related, so when the epidural comes out, you can get obstructive type symptoms, which can be a problem. We've talked about using Botox, but haven't need. It's hard to pick which ones are going to have problems. And suture placement depth is probably key. If it's covered with a stoma, we don't seem to have this. It probably is pain related. Later complications, I'm not giving data because I was asked not to, but we do get constipation, but perhaps not that bad. But we don't see incontinence at night, which is something I had seen before when I've seen transanal only procedures. We do see enterocolitis, as everybody does, but not quite as severe as I've seen with other procedures. But I think that may be because we use vancomycin, or we try and manipulate the microbiome a little. But that's really hard to study, so I can't give you microbiome assay data, but I'd love to be able to do that. We also, in terms of complications, we think of whole of life type complications. So every year, at least once, we'll bring them back to an annual review, as well as clinics in between. We do standard follow-up, but we go through the core outcome data sets. We do have limited ability to collect metrics objectively, which we're working on. We ask families for ideas and suggestions for service improvements as part of that. And then importantly, we confirm what the threshold should be, families to contact us if they have problems, and that the contact details they have are correct, because they quite often aren't actually, and that's an important thing, to actually be functional with the follow-up. We'd like to say thank you to teachers from when I was younger and colleagues now, particularly Ian Sugarman and my colleague Chris Parsons, and theatre team, clinical nurse specialists who keep everything ticking over, and our clinical psychologists. I'd like to say thank you to my colleague Syed who helped with the diagrams. And that's it. Thank you very much.
Thank you, Jonathan.
Thank you.
Jonathan, just a question. You have great teachers. This was a very clear talk, a very nice talk. For how long, what is your learning curve? What is a learning curve normally for a junior surgeon? Because you had many teachers, but it's how many procedures do you have to do? What do you think? How could people when could they do it on their own, or do you always do it with 2 surgeons? What are your thoughts about that?
Well, I love that question. I think it should be goal orientated rather than number orientated. I think the way you train is really important. I loved what your team do. I think having a video then linked to a dry lab where you do a number of the steps together. It's like teaching sport, teaching rugby. You do whole part whole. You look at the whole of it, then you break it down into parts, and then you do the whole together. You do that, then your mindset is better for the first time you go to theatre to actually start doing some of it. So I think you probably get up the learning curve a lot quicker. So actually that then maps to how effective your program is at education. We would hope that by the time our fellows have finished, that they would be able to do all of the steps independently. But actually, I would advocate we try and have it that there are 2 attendings around for most index procedures. Important though to remember that the education's there. So what you don't have is 2 attendings doing the whole procedure. What you do is you sequence it beforehand to make sure that the fellows and the registrars, we call registrars, each know what bit they're going to do beforehand and rehearse it. And I think that way they get up the learning curve, you've got better governance. That's what I think. I learn a lot as well.
Yeah. And I also noticed that it's not always the technique, but there are still differences in the cases and the choices. At least that's with the transanal sometimes. It's not always this this video looks very elegant and easy sometimes to do, but like in the transanal procedure, which I am much more familiar with, it can be difficult sometimes to get in the right plane. Any surgical procedure, I think, is always very often is finding the right plane, being in the right plane. Is this easier in Duhamel, or are there sometimes difficulties also in finding the right retrorectal space, for example, or finding the right site where to open? You say, I open it at the dentate line. Is this always easy to see, or are there cases in which it's more difficult to decide? Meaning there are...
Yeah, dentate line. So I'll start with that one. It's classically really easy to mistake the dentate line, and actually people go to the anal cutaneous margin by accident. So what I always do is, as well as starting at the anal cutaneous line and looking up, I then sense check it by going up to the colonic mucosa and come down. And if those 2 points are the right point, then you're right. And if you're not sure, then actually make sure that you've got a colleague that says, do you agree? So that's important. Now, I'm going to humbly say, I respect what you say about the planes. I think planes for a PSARP can be quite hard. And reflecting on what you say, the retrorectal plane for this is relatively easy. If you get it, if you open it between those mesenteric leaves and get in, you're into an areola plate, so you can just drop down. So I can honestly say I've not commonly had problems finding that plane. But other things that I think are hard, you've got to keep the focus going. Maybe it's me, but we're quite slow. I don't worry about that because the long-term outcomes are really important. So I'm going to humbly say I don't think planes are the thing for the Duhamel. Getting the bottom end right is important, and getting that suture placement, I think, is really important.
Okay, I think for time's sake, maybe we should go to the next. Or Ramon, do you have any question? I see you're hesitating, or we can go to the next talk.
Thank you, Ivo. So, Jonathan, thanks for the talk. I just had one short question. Is there any age preference that you would like to do the surgery, or what is typical in your clinic? Around what age do you do your procedures?
Yeah, so we have them on washouts at home, so I don't like to leave them that long. I think typically it's going to be about 3 months. And you might say that I don't know whether that to you seems like a long time. I know other people do it a lot younger. I'll be honest, I think that you're practice sometimes doesn't change as quickly as you'd want it to. You get stuck with 1,000 other things. Maybe we should be doing it slightly younger. The thing that I worry about, Ramon, is the one thing that I don't like is I don't like the idea of the discomfort post-operatively that makes them hang on. You know, when the epidural's out, that makes me uncomfortable. But once they've gone through that, that's the key phase of this, I think.
Okay. Thank you. So I think for time's sake, we can go to Joep and Ramon for the transanal resection perspective. And while they're working on this, Jonathan, maybe another question then. I've seen that some people put in a post-operatively a catheter transanally. You don't have this in your post-op protocol. It's because some people think there could be some delay in stool, or they're afraid to do the washouts straight post-operatively, or putting in a catheter after the surgery, so they leave it behind. But it's not your policy. They stool treated straight away normally.
Yeah, I've not heard of that. I mean, they'll generally stool after about 2 days. I've not heard of putting a catheter in, and we haven't done washouts post-operatively, or I think there's been one in our centre that's needed washouts to begin with, but it's not a common thing. And when I've heard that for other procedures, I've thought, you know, I'd love to spend, you know, a little bit of time watching the post-op recovery for different procedures and see how that goes. I don't know, is that something that you've seen, or?
I think the clinic in Utrecht, but I'm not, I shouldn't be talking for them, but I think they used to leave a catheter for the first couple of days, just to not to have a blowout of the pouch, and to have it smaller.
Yeah.
Generally, you do kind of things because something happened, some kind of complication, but it's not for us maybe to talk about. I do think you hardly see any stenosis, I guess, with the Duhamel, because the procedure is, if you do it right, it's very difficult to get a stenosis, because the anastomosis is very long and wide, of course, and you only use half of the dentate line, I guess.
Yeah.
Other than the transanal procedure or any other circular procedure, Swenson, Schwabe, or Rabine. Okay, I think we can go now to the Amsterdam crew and hear something about the transanal pull-through.
Thanks. Yeah, we had some problems with sharing our PowerPoint presentation, so I think Luz has got it open right now, so that's very good that we finally can see it. Yeah, thanks, Luz, and thank you, Ivo, for the introduction and for organizing this EUROGEN ERNICA webinar. Next slide, please. So I'm one of the pediatric surgeons in Amsterdam, and what we do is the endorectal pull-through in short segment disease, and I'd also like to guide you through the surgery as we perform it, and also tell something about our complications if you've got time for it. And the next, please. And the next one.
Hey, for the record, it's always nice to talk about complications of others, not my own. So I have time enough.
We published about it, so I'll share it honestly with you. Well, what we do in Amsterdam is for a short or long segment disease. So if it goes longer than the splenic fractures, we always try to do a laparoscopic assisted pull-through. And for total colon aganginosis, we do the Duhamel. But since this topic is about the short segment disease, I'll of course tell you something about the pull-through technique. And the next one. In the 1940s, Svensson described his first definite repair of Hirschsprung disease. So this is a little bit of history. He always performed a colostomy and then did a laparotomy, and then he did a complete dissection for the Hirschsprung disease part, and end-to-end anastomosis above the anal canal from inside, so via the laparotomy. Now later Duhamel came and Jonathan explained it, so we all heard and learned from him. And then Suave came in the 1960s, and he did the first description of the anorectal pull-through. What he did is that he did a laparotomy, he splitted the intestinal wall and created a seromuscular layer, in which he separated this one from the mucosa layer, and then he dissected from the laparoscopic approach as deep as possible. And then from the perianal stage, he introduced the catheter, as you can see on the right, into the lumen, and he tied it up around the mucosal tube. And then he performed a pull-through, cut the intestine, and created the anastomosis. So this was a real pull-through, so to say. And then in the next slide, because then came De La Torre, and I think we all know that one because he deserves quite some credits together with Professor Lange for the first transanal anorectal pull-through. And this surgery can be done in prone position or in supine position. And I think these figures are from a prone position. He started opening the anus via a Lone Star retractor, and then he started the mucosal incision about 1 centimeter above the dentate line and put the retraction sutures around it. And then he stripped the mucosa actually from the muscle, such as Suave did before. And after 1 to 3 centimeters, and that's on the next slide, please. He incised the rectal muscle. Yeah, there you can see it in C. And the dissection went up and up and up along the rectal wall. He easily said that you could divide the vessels, and the only thing you have to be worried about is not to twist the bowel, but to really get it on via the anus. And once the surgeon then reached the normal innervated bowel, so the non-Hirschsprung disease, indeed you could see this. And what he had to do is divide the bowel. He split the rectal muscle cuff so that it didn't cause any strictures, any problems. And then he made the anastomosis as shown in number G. And then later on in the 1990s, Georgian came with the first laparoscopic approach. And that's how we still do it in Amsterdam with some small modifications, as I will tell you about. So can you please do the next slide, Luz? Yeah, these are some advantages. Sorry, I forgot about that. You can do this transanal pull-through everywhere in the world because you don't need that much special stuff. He didn't have to perform a laparotomy, and that was, of course, what Suave and what Svensson had to do. So it was cosmetically really nice. Maybe some side things is that with a really longer segment of Hirschsprung disease, it's difficult to go completely transanally. That if you have a bleeding intra-abdominal, that you might have some problems stopping it, and that you have to take care of twisting of the bowel. And then the next one is about Georgian's laparoscopic pull-through. So next slide. Yeah, he described it in the 90s, and he placed the ports in this positions. And then on the next slide, I'll show how we do it. Yeah, so we mostly put the kids on this position on the table. Sometimes if the kid is a little bit younger, you can also do it transversely. And then we start with a trocar via the umbilicus, put in a 30 degrees camera, and then on the next slide. Yes, might come. The first thing you're going to look for then is the caliber change, in other words, the transition zone. And you could immediately do a single point seromuscular biopsy, as you can see in the next slide, which comes really slowly. However, we stopped doing this, and I think because of the same arguments as Jonathan gave, is that with this single point biopsy, we published that in about 250 kids, we had a transition zone pull-through of about 10%. So what we do now is at the end of the surgery, once we did the pull-through, we also send a donut to the pathologist who we informed days before to be ready for us. And only then we start creating the anastomosis. So we don't do a biopsy in first instance, but we just place a suture where we think that we are about 5 to 8 centimeters above the caliber change. And we start then dissecting the mesocolon. That's on the next slide. And that's a really nice thing about the laparoscopy, I think. You can really start open the mesocolon precisely because of the magnification of the camera. You can see it really good. We use a cautery hook for this procedure in these babies and divide the vessels, take care of that we have a look at the ureters, at the vas, once we go deeper below the peritoneal reflection. And on the next slide. yeah, what we do then is at the end of the laparoscopic phase, we go and check if we have enough length to pull it down deep into the pelvis. And then if we are happy with that and we don't have any bleeding anymore, we start with the anal phase. And I think we do more or less the same. So we put a Lone Star, not exactly the same, but we use most of the times a Lone Star retractor. We incise the mucus about 1 centimeter above the dentate line, and then start creating a plane. And we don't leave a cuff there, but we immediately go full thickness, and so that we only have a really short dissection from the anal phase, because we can reach the laparoscopic resected phase quite soon, and then we do the pull through, and then we take the donut, and then it's easily to do the anastomosis again. So that's a little bit of a of another approach, that we don't leave a rectal cuff anymore. Once we do it, the anastomosis, and of course we hear from the pathologist that we have nice ganglion cells all around in the 4 quadrants. Then we do one last inspection via the laparoscopy to check if there is an internal herniation of the small bowel under the colon, if we have any twists of the colon, and if we have any bleedings, so that we really are sure that these things are good. The next slide, please. Yeah, so that's some advantages, I think, of the laparoscopically assisted transanal pull-through, is that you really have an early visualization of the transition zone. You can mark it, that you can mobilize your rectosigmoid, that you can also go upwards towards your splenic flexure if you need some more length. So also for long segments of Hirschsprung disease, it's really good to perform that we have a short anal phase, because we meet the laparoscopic dissected bowel quite soon, and that we can early visualize bleedings. We can see that there are internal herniations, or if there are any twists of the bowel. Of course, you can't do it everywhere in the world, because you need this laparoscopic equipment for babies. For example, the 3 to 5 millimeter cameras, the small baby instrumentary, and that's what you need for it. And the next slide. There are some studies, but yeah, I just put on this one, but there are others to be found, and they also show the other way around, of 200 kids from the Nordic countries. And if you have the next slide, they tried to compare the laparoscopic approach with the transanal only approach, and they defined poor outcome as having a stoma, appendicostomy, being on enemas all the time. And what they showed is that the laparoscopic approach had a better result, so that they didn't have that much poor outcome. In the next slide, you can see where they showed it. But I immediately agree that there are also some other studies which show the opposite around. I only think that this is quite a nice study, because it's multi-centered. It has quite some kids. Now, next slide, please. Yep. About the complications, which Ivo likes so much. The first one we reported honestly about it is the group from Sweden. And in the next slide, they reported about 69 kids, and they divided their complications into the Clavia and Dinder grades, being minor complications grade 1 and 2, being major grade 3, and they only had one grade 3 complication, namely that a kid had an abscess for which they had to do had to create a stoma. And the next slide. We also report on our complications recently in 106 kids from the last 10 years, and 22 out of them developed the complications. And then in the next slides, and you can do, yeah, we had some minor complications, as you can see here, some wound problems and some other problems, but also some major complications. And the 2 deaths that we reported were all because of that we had to do some really early transanal irrigations after the surgery, because that's what we quite often saw in these pull-through, after the pull-through procedure, that we really had a distended abdomen, and that we had to start irrigation day 2 or 3 after surgery, and that we made a perforation, probably in this anastomosis, soon after surgery. And unfortunately, we lost 2 kids because of this really nasty complication. The next slide. Yeah, and the next slide, please. I will go over this quite soon. So these are some of these complications I just showed you from the Swedish group and from our own group. And then the next slide. because what we change now in our procedure is at the end of the surgery, we leave a drain transanastomotically, because at the time we had this complication of the perforation after the rectal irrigation. We thought, well, what to do? And this study came out from a Chinese group who did a multi-center prospective study. And what they showed, if you have the next slide, is that in the drain group, which is group A, they had definitely less abdominal distensions than in the group without a drain, and also less Hirschsprung associated enterocolitis. That's what we also see right now. We do it for around 2.5 to 3 years now. With this drain, we always are comfortable because we only have to rinse the drain a little bit to keep it open, but the kids can pass their stool, can pass the air immediately after surgery. We are not in trouble anymore that we have to do the irrigations. And if you remove the drain, then the anastomosis is healed quite well. We don't have any complications with regard to the anastomosis, and the kids can go home with a safer feeling in our hospital now. So next slide, please. Yeah, then maybe we should not talk about these long-term outcomes because of the time. So if you can click a couple of times, I'd love to talk about this. Yeah, and just a couple of times in another session. You know what you have to take care of in the long term, and that Botox is a great therapy to prevent all kind of obstructive disease and all kind of enterocolitis kind of things. Next slides. Yeah, please go through it, Luis. Yep, and also go through this one. Yeah, and so this is what we have learned, that the quality of life after this transanal pull-through is quite good, but we have some major short-term complications that I think we should try to avoid transanal irrigations soon after surgery. So that's why we leave this drain, for example. That you also have these long-term complications, which I would love to talk about later on, but that then Botox really rules and that it helps us out quite often. The next slide. Yeah, this is the team that we're working in together with the gastroenterologists, our 2 pathologists who are dedicated to babies and children with Hirschsprung disease, our radiology department, and of course our colleagues from the surgical department. So thank you again for the opportunity to present, and thank you for your time.
Well, thank you, Joep, for this very honest and presentation and good presentation. I don't know if Luz has any questions. Otherwise, I will. Maybe we can discuss a little bit about Botox. And you raised several questions on which could be discussed further, meaning long-term outcome, difference between Duhamel, TERPT, and even short-term outcome complications. I think to compare them is very difficult because there's a lot of different literature, but there's not one randomized trial or good comparison. Maybe a little question on Botox, but we'll have a separate webinar as well, I guess, on Botox once. For the Duhamel, Jonathan, do you think Botox has a role there as well? Do you use it in case of obstruction?
Yeah. So for children post-operatively who aren't doing well, do all the standard things. We don't tend to see strictures. Make sure there's not a spur. If I'm bothered, I'll take them to theatre and I'll put a scope in to visualize it, because then you've got your eye in about what's normal. But I'll consent them for Botox, because if I think the hold up clinically and radiologically, so that means that the pouch is distended and the staple line's far apart, I'll think that it's probably the anal canal, and I'll do Botox. And I've now started using ultrasound to guide me. I go to the internal anal sphincter. Joep, hello Joep. You'll be the expert in all the different papers on this, but I think I always target the internal sphincter for Hirschsprung disease, and I use ultrasound. And I think about 50% of the time it's influenced where I put my needle. So that's what I do. I don't know what you guys do.
Yeah, we don't do it with ultrasound. We did this large systematic review, and I just go through very rapidly. In the systematic review, about half of the children received their Botox ultrasound guided, half of them did it just by palpation and having a look where the sphincter is, and the results are exactly the same. So we chose not to use the ultrasound anymore, or not the ultrasound, but just palpate it, and then put the Botox on the foreplace.
So and like Jonathan said, well, first I look for spur, I look for other things when the patients are obstructive. What is your policy in Amsterdam when they get obstructive? Do you first try Botox, or you first analyze everything, and how far do you go with analyzing or reanalyzing your pathology or anything? Yeah, how do you deal with a patient who is 2 months post-op and obstructive?
Yeah, we first let the pathologist review the slides again. Then we do a contrast study, so a colon contrast study to be sure that there's indeed no twist or any other reason for the obstruction. And then we really soon have a place for Botox. So we don't do a really large investigation, but these are the two most important things, and then we go for the Botox.
So Ivo, I see some questions coming from the audience, and maybe I can ask, I think this one is addressed to you. So in case you do the pull-through, how do you prevent the ischemia of your pull-through segment? Do you got any tips for that?
Yeah, what my tip is to stay really close to the colon and the rectum, so that you are not going to divide the vessel centrally, but that you really stay to your colon and rectum, and that's quite easy to do. And then we hardly have any ischemic kind of problems.
Okay. Yeah, just another one from the audience. I think this one is for Jonathan. It's for in the Duhamel procedure, and I think you might talk a little bit about it. But the question is if you can prevent twisting of the bowel. So how do you try to prevent this when you're doing your procedure?
Yeah, I've had that happen when I was a reg, that it was my fault. So I've been paranoid since. So before you actually pulled it through, mark it with one suture anti-mesenteric, one on another, write it on a board. Then track it right the way up to the mesentery, and then follow the mesentery down to the retroperitoneum. So you know it's not twisted at that point. Now it can happen if you've got a relatively fair amount of bowel mobilized and you've gone up a fair number of arcades. You can easily, that's how we got it wrong. It looked absolutely fine in the bowel, you could see. So after you've done the actual pull through before stitching it in place, then you need two assistants, one to keep the ureter and vas and things out of the way, and the other one to make sure things aren't getting twisted. And you've got to be able to trust them both. Then you look up, and then before you stitch anything in, make sure there is no twist. And make sure it's not lying across anything like the duodenum or the small bowel, because that can happen actually. I hope that answers the question.
Ramon, are there any more questions? I think we're almost at the end of the webinar. I just have maybe one question for you, a personal question as well, because you perform the Duhamel and the TERPT. You do both the procedures, different diseases, but both procedures. I just asked Jonathan about learning. What do you feel most comfortable with? Is the Duhamel like an easier procedure, or is the transanal like an easier, or doesn't really matter? What are your thoughts about it?
No, it's not a big matter, to be honest, but if you really have to choose me, I would go for the laparoscopic assisted pull-through. That's that I feel the most comfortable with, to be honest. And I think it's a bit easier.
And the laparoscopic Duhamel, is this because Jonathan spoke a little bit about it? Did you do it laparoscopically, or is this?
No, we always do it laparoscopically. And we leave the, if you create the pouch, we leave the native part open until the end, and then we do the staplers, so that you really make sure that with the stapler apparatus, you can see it coming through the bowel. And then at the end, we close it with some stitches, and then it's really good doable, to be honest.
So, okay, then I think if Luz agrees, because I think it's 7 o'clock already, I'd like to thank you all for presenting and being honest. And I think we will have other webinars as well on the complications or on Botox or other issues that are obviously also needed to be addressed. Thank you very much. And I don't know if Luz still wants to say something. She may want to finish the webinar.
Yeah, I totally agree. I think I want to like to thank all the presenters and of course also the audience for joining us tonight. And I just wanted to say that the webinar has been recorded and will be available on our GoToWebinar platform and the YouTube channel. I will send these links for you tomorrow. And all of you who have attended today will receive a survey immediately after the session finishes. And we would be very grateful if you could spend a few minutes filling it in. So for now, I would like to thank you all and wish you a very good night. Bye.
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 Top teams.